The standing evaluation. The patient is going to be standing with their feet as comfortable. Usually you'd like this to be parallel, but it's important to notice how their normal stance is, whether their feet are everted or inverted, or how their normal stance is. So you just want them to stand as comfortable. The goal is to evaluate the closed chain static mechanism, and this can help you predict how the patient might ambulate. Anterior, posterior, and lateral views. Some of the spinal curves you're looking for are kyphosis, lordosis, and scoliosis. Next, observe for pelvic tilt or obliquity in the frontal plane, the sagittal plane, and the transverse plane. A normal neutral tilt, according to Jenny McConnell, is the ASIS is 15 degrees in front of the PSIS and in the same plane as the pubic symphysis. Femoral or hip anteroversion or retroversion, you're going to observe this. An easy way to tell if the symptomatic anteroversion, if the femur is ask the patient to squeeze the gluteal muscles, and observing the posterior view. With the gluteal flexion, the femurs will externally rotate. While evaluating the patient from standing, it's also important to observe for gluteal bulkiness or roundness, as Jenny McConnell likes to put it. Lack or uneven amounts of gluteal development, particularly in the gluteus maximus and medius, that usually results in the internally rotated femurs. Quick fix when you're coming to rehabilitation. Well, not a quick fix, but an easy fix, easy solution. Genu varus and valgum and recurvatum with the knees. Varus patients will compensate by pronating to get the great toe on the ground, and with knee valgus, they'll exhibit the fifth metatarsal off the ground. Therefore, the patient will supinate to compensate for this, typically. With tibial torsion, you're going to look for internal or external rotation of the tibia while they're standing. Pronation or pes planus or supination, otherwise known as pes cavus, is another thing you're going to be looking for while they're standing. Be careful not to make a judgment based on the standing observation only. It is important to understand the need for both supination and pronation during normal gait. When the patient ambulates, the observation of pes planus or pes cavus may change. A lot of times you see a patient walking and they're able to compensate for their what would be viewed as pronation or supination. Next would be navicular position. The navicular position should be evaluated in relation to the other midfoot structures. Specifically, what you're looking for is the cuboid and the calcaneus and the position of the navicular to those structures. With pronation, the navicular will lie in a parallel plane as the cuboid, and in neutral, the navicular will lie in a plane slightly above the cuboid. It's creating an angle. With supination, this angle will increase and the navicular will ride almost entirely above the cuboid. Hallux valgus is fairly easy to spot in that it typically results in a deformity known as a bunion. So that's hallux valgus. Toe position such as clawing is also important to note, and it may indicate the body's attempt to stabilize. So those are important structures to look at. Some hints from Jenny. These were pretty valuable to me when I was going through her presentations. An ideal foot, not in supination or pronation. The curves of the malleolus, and you can see in this patient, the curves of the malleolus above and below are fairly equal. And with supination and pronation, those curves might not be equal. More hints from Jenny. The medial calcaneal angle, it increases with supination and decreases with pronation. So with that, the subtalar axis normal is usually around 42 degrees. In pronation, it looks closer to, around 20 degrees and results in more foot problems. When it's supination, that subtalar axis can be up to 68 degrees, which results in tib-fib problems such as shin splints. So this describes that. Closed chain pronation results in eversion of the calcaneus, abduction and plantar flexion of the talus and the lower leg internal rotation. And the opposite is true for supination. It inverts the calcaneus. Sorry, abducts and dorsiflexion of the talus, and the lower leg externally rotates. This was a good one too. I enjoyed seeing this callus pattern For a compensated forefoot valgus, you'll often see a callus between the second and third med head. For uncompensated forefoot valgus, you'll see calluses on that fifth med head. You can't see in this picture as well. It is a patient of mine, but you can see if you look hard enough the callus formation under the fifth med head. So you can say that this patient may have a forefoot uncompensated forefoot varus. Compensated rear foot varus, there's often calluses under the second and third met head. Plantar flex first ray, you'll see a callus under the first metatarsal head. An uncompensated rear foot valgus is, you'll see the callus on the lateral heel and on the fifth med head. So you can say this patient might have an uncompensated forefoot varus or an uncompensated rear foot varus based on his callus formation. Shoe wear is also evident. It can tell you a lot about that, so make sure you pick up your patient's shoes. A rear foot varus and valgus is evident. It might be very evident in the wear of a heel of patient's shoe.